It doesn't matter whether your expertise, your passion is metabolic disease, weight loss, autoimmune disease, hypothyroidism, or any of the other common chronic disease dynamics that are at play in our patient and client populations today. You must also master the functional imbalances common in perimenopause. Why? Because if you're passionate about the functional medicine lens, you have to acknowledge that the typical patient or client seeking support from any type of practitioner in the realm of functional medicine is a woman in her 40s, which means statistically she is very likely to be wrestling to some extent with the natural, inevitable transition in life called perimenopause. Welcome to Functional Medicine for Real World Impact, where we're diving into the complex, interconnected nature of health and disease, exploring not just theory, but practically what it takes to turn functional medicine insight into powerful, practical, real-world results. So please hit subscribe and let's get started. This is Tracy Harrison from the School of Applied Functional Medicine, and I'm delighted that you're seizing the opportunity to join us live today to talk about surprising practitioner pitfalls in perimenopause. And I've got 5 key concepts that I want to review with you. And the 5th one is the most important. We're going to get into hot flashes and what's really at play and what actually works. But I want to dive right in because many practitioners are passionate about helping women to better navigate this transition, this phase of life. I think it's a real mistake to think about perimenopause as being a medical problem or a diagnosis or a syndrome. It is an inevitable phase of life. And in many women, the transition is not a short or acute event. It is something that can last as little as 2 or 3 years, but much more typically 7, 8, or maybe even 10 or more years of their life. And I think a critical concept to understand about perimenopause is that the only constant during this window of life is change. And I think it's a real clinical misstep to think about having a protocol in perimenopause because whatever works for a given unique woman right now is probably going to be ineffective in 3 months' time, 6 months' time, 9 months' time, because her body is constantly shifting during this transition. Dr. Laura Briden, who has written extensively about some of the important biochemical nuances at play in perimenopause, has famously called this window of time a second puberty. And I think that's an awesome model for all of us to have about perimenopause, because in the same way for a girl, typically a preteen or a young teenager is experiencing with menarche and their slow acquisition of sex hormones, this happens over a window of time and it tends to be fairly erratic because it's a transition from the stable time of low hormones in childhood to the more predictable cycling of hormones during a woman's fertile years. But it's an erratic time where as estrogen is acquired in the body, progesterone is slow to be acquired as well. And this is one of the reasons why a lot of young women can experience symptoms of estrogenic overload, or what we sometimes call estrogen dominance. Where there's not quite enough progesterone yet to balance the surges of estrogen and estrogenic effects that she might be experiencing. Similarly, in perimenopause, there are a number of hormonal shifts happening. And in particular, progesterone is often the first hormone to progressively be lost over time. The women, when they ovulate, begin to make lower and lower levels of progesterone, and then they also will have episodic and ovulatory cycles. And if a woman is not ovulating, she is not making ovarian progesterone. And so it's a transition period of time, and the length of perimenopause and the fact that hormones are shifting in various directions over time in each unique woman means that we need to have a nice big toolbox and become skilled at assessing what does this unique woman need, right now. There again, the concept of a protocol for perimenopause, I think, is misguided because what works for one woman right now is likely not going to work well for another woman, and it's not going to work for this same individual woman at a future point in time. But during perimenopause, as I said, a drop in progesterone is often the first change. And this may take place during a time, the first third or even half of perimenopause, when a woman's estrogen levels are remaining stable. And the drop in progesterone can create a relative estrogen dominance that might increase estrogenic effects in her body. She may begin to experience heavier menstrual bleeding, more symptomatic PMS. She may have menstrual or hormonal migraines for the first time in her life. She may be experiencing greater levels of mood imbalance, more anxiety or worry. She may suddenly start having trouble sleeping. And these symptoms may be worsening for her based on what she's experienced in the prior couple of decades, or it may be in perimenopause that she's experiencing these symptoms for the first time. And this surprises a lot of people, but it also sometimes surprises a lot of practitioners. We have been falsely led to believe that during perimenopause, our estrogen levels are making a slow trek downward. And the data is even really misrepresented in a lot of visuals or graphics in patient education, as though somehow it's a slow, steady, linear, predictable curve downward. And nothing could be further from the truth. Estrogen, if anything, is erratic. And often in the early stages of perimenopause, while the brain is really still trying to get the ovaries to respond normally to menstrual cycles, and the ovaries are not so interested in doing that, women's estrogen levels might actually go up during the first few years of perimenopause. And higher estrogen and lower progesterone can certainly make for a window of frustrating symptoms and estrogen dominance. But let's dive into the concept of lower progesterone and some of the common symptoms and the pitfalls that can be at play in managing this imbalance. Because again, progesterone usually drops first, typically several years before estrogen might start to drop. And even the drops in estrogen are often quite erratic, episodic. It may go down for a while, it may come back up. But the slow, steady downward progression of progesterone often creates, in particular, mood imbalances. And we know progesterone is necessary in the body for balancing estrogen. They're actually synergistic hormones. They're not antagonistic. But in particular, lower levels of progesterone in the context of stable or higher estrogen create anxiety. And this may manifest as ruminating or worry or hypervigilance. A woman may feel depressed over time, actually, because she's wrestling with so much anxiety. In particular, this can affect her sleep. And we know that if we don't sleep well, we tend to have higher levels of stress hormones. In fact, you only have to have one night of poor sleep in order to have higher levels of fasting cortisol the next morning. And if this becomes a chronic lifestyle pattern, then cortisol levels can become markedly elevating, of course, exacerbating her experience of stress and anxiety. And progesterone plays a key role in mood via a number of different pathways, but in particular, because when we metabolize progesterone, the alpha metabolites actually play a strong role in promoting GABA. GABA, the calming inhibitory neurotransmitter. And we know many of our patients struggle with anxiety or hypervigilance because they have GABA glutamate imbalance. GABA, again, being that most prevalent inhibitory or calming neurotransmitter. We need that so that we can relax and rest the mind and actually calm the mind enough for melatonin to work so that we can indeed go to sleep and stay asleep. Glutamate is, of course, essential for our focus and our drive, our concentration, our analytical skills and problem solving. And we want that when we're awake and working. But when we struggle with the ability to oscillate readily between the calming effects of GABA and the stimulatory effects of glutamine, this can lead to worry, anxiety, and poor sleep. And as progesterone goes down, it is expected, it is natural actually, for GABA function to be lessened. And this means that a woman's mood balance, her emotional vitality, and feeling of stability is really going to depend on her stress management skills. And we can think about using some of our tools, especially during this window of time when progesterone is dropping while estrogen is staying stable or rising. Things like taurine or magnesium or L-theanine can all help to promote higher levels of GABA. And certainly some women really benefit from oral GABA oral GABA, yes, but also oral progesterone. When we take progesterone orally, of course, the majority of it is well absorbed and goes through first pass hepatic clearance and metabolism in the liver, and this leads to lots of alpha metabolites. And so this is where micronized oral progesterone can be helpful for potentiating greater GABA, especially in the evening time, in order to allow good sleep. Now, not all women can tolerate oral progesterone or any progesterone for that matter from a supplemental viewpoint, but I think it's important to have a big toolbox because a common misstep in perimenopause is either thinking that all women need bioidentical hormones or thinking that none of them do in terms of optimal clinical tools. This is where a protocol, a standard one-size-fits-all approach can really lead us astray and lead to suboptimal clinical outcomes and also lower satisfaction for you as a practitioner. But I want to mention in particular the role of alcohol, because this is something I think we need to do some truth telling with our patients and clients about. Many people are used to using alcohol, especially consumed in the evening during the week, to help promote greater levels of GABA. They feel calmer, and they may be used to, in the earlier decades of life, this helping to promote sleep. But unfortunately, as we age, we become more vulnerable to what is called glutamate rebound. Now, when you consume alcohol, the inhibitory effects of the alcohol do help to calm the brain in order to allow sleep. But of course, the brain is not interested in being artificially suppressed. And as the body metabolizes the alcohol in the first few hours of sleep, there is a classic glutamate rebound that happens. And many people find themselves awakening 2, 3, 4 hours after going to bed, having consumed some type of alcoholic beverage, and they are awake. In many cases, they feel wide awake. And this is because the brain has experienced a surge of glutamate, the stimulatory neurotransmitter. And suddenly we're thinking about all the things, and it can be very hard to go back to sleep. So we want to think about the role of the progressive drop in progesterone in promoting this mood imbalance and these challenges with regard to GABA, and having a good, rich toolbox that we can use to support these women. But in addition to mood imbalance, another common pitfall with lower levels of progesterone has to do with histamine. And I think this is the functional imbalance that is most often overlooked in perimenopause, because many perimenopausal women have histamine overload. And that may surprise you, because we often think about histamine being something that primarily is a expression of and a modulator of the immune system. And that is certainly true. We often associate histamine overload with chronic nasal or respiratory sinus congestion and postnasal drip. But histamine mediates a lot of different body systems. And it actually functions as a stimulatory neurotransmitter. It promotes hypervigilance and wakefulness. And sex hormones modulate histamine. And in particular, as our progesterone levels go down, we may struggle to optimally degrade histamine. And so naturally, we end up with higher levels of histamine, especially in the gut. And this can wreak a lot of havoc on a woman's experience. It might create gastrointestinal bloating or maybe diarrhea. It might promote worry and anxiety. But in particular, this can also cause problems with sleep. Surges of histamine for a variety of reasons during the night can also promote wakefulness. Now, going back to the topic of alcohol, this is something to consider because wine is a very popular beverage for perimenopausal women, at least here in the US, and especially red wine. And red wine, a glass of red wine right before bed can often be a triple negative for women. First of all, because red wine is loaded with histamine. And this histamine, despite the fact that the alcohol is calming, the histamine is stimulating. And as she consumes that red wine and the histamine is aggregated in her gut and quite a bit of it is absorbed, she may find herself struggling to fall asleep or struggling to stay asleep. Anything that is fermented or cultured is going to have marked amounts of histamine in it. But it's also the fact that alcohol, as I said, is going to potentially promote glutamate rebound, making it hard to really stay asleep and to have good, deep, restful sleep for a sufficient number of hours overnight. But there's also an interesting dynamic where the degradation of histamine and the degradation of alcohol compete for enzymes in the body. And so when we are consuming a glass of red wine at night before bed, you can start to see how the histamine, the alcohol, the lower progesterone levels can create a bit of a perfect storm that despite her intentions otherwise, this much desired glass of red wine may actually be markedly interfering with sleep. But I also want to talk about estrogen. And this is a third key concept for practitioners to explore. And this is this notion of expecting that for many women in the first half of perimenopause, however long that is for her, which again, the first half of perimenopause might be 3 years, 5 years, 6 years, her estrogen may not notably go down at all. In fact, it might go up. And in particular, if she has marked body fat, we know that adipose tissue is endocrine tissue. Body fat makes estrogen. Her net estrogenic experience might not begin to really trend downward until quite late during the perimenopausal transition. And as I said, many women experience estrogen dominance types of symptoms with heavier menstrual bleeding, more anxiety, more mood imbalance, body fat gain, especially in the torso and in the belly area. She may struggle with appetite challenges and overeating. She may have migraines and headaches. But if you're savvy and realizing that net estrogenic effects might be going up, then this is where these women may really need support with reducing estrogenic overload in the early stages of perimenopause, which surprises a lot of practitioners. And this is where we need sufficient B vitamins for methylation to help with estrogen metabolism. We want to consume plenty of cruciferous vegetables and other foods that have phytonutrients in them that help to trigger the NRF2 antioxidant pathway in order to help the body to better navigate estrogen and estrogenic effects. We want to ensure that we have good bowel movements and good GI motility so that estrogenic waste products and estrogen metabolites are readily excreted in the body. These are things that we want to address in terms of making sure that estrogenic loads are appropriate for a given woman. We can also use things like DIM or indole-3 carbinol as a supplement in order to increase phase 1 estrogen metabolism in order to reduce net estrogenic effect in the body. But this is where we have to really consider, who is this person? Because some perimenopausal women may be in this situation where they're quite estrogen dominant. That may be being exacerbated actually by endocrine disrupting chemicals. This is the myriad different chemicals in everyday use in our lifestyles that can be either mimicking estrogen and estrogenic receptors, or that might be modulating the behavior of enzymes that are involved in estrogen metabolism. But on the other hand, a woman with markedly lower body fat who has a very clean lifestyle, she may be experiencing net lower estrogenic effects earlier in perimenopause. Given the typical American woman's body composition, that's going to be less common, and certainly less common in our practices. But we need to remember that the progression of perimenopause is going from a state of ovarian control of sex hormones, especially estrogen in her body, to a time of more adrenal control, or I like to say the 3 A's: adrenal, adipose, body fat, and aromatase, right? Aromatase, the enzyme that actually converts a woman's androgens into estrogen. We're moving from ovarian control to this other type of hormonal control in the body. And women without a lot of body fat, without a lot of endocrine disrupting chemical effects, with good methylation, she may experience lower levels of estrogen and be experiencing migraines for that reason. And this is where certainly bioidentical estrogen, especially transdermal or vaginal, may be appropriate for her. But many women also find relief from things like isoflavones, from maca, from ground flaxseed, and other tools that can help to provide more phytoestrogenic support, especially activating the beta estrogen receptor. And so we have to really ask, who is this person, and honor bioindividuality in considering what are a woman's estrogen needs or estrogenic needs in perimenopause, given where she is right now in that transition. Now, the fourth pearl I want to talk about is the dance of estrogen and serotonin. Many practitioners, it surprises me, in our classes and in our case reviews at SAFM, many practitioners are unaware that there's a strong partner dance in the body between estrogen and serotonin. Estrogen dramatically mediates serotonin synthesis. We need estrogenic effects in order to have optimal serotonin synthesis, to have increased duration of serotonin in the synapse, so extended effects of serotonin. And this is important for mood balance, for GI motility, for impulse control, and lower levels of serotonin or serotonin neurotransmission can lead to a lot of the hallmark symptoms of later perimenopause. This is increased aches and pains, because serotonin mediates pain perception in the body. It may be a low mood or depression, or swings between anxiety and depression, because certainly serotonin plays a key role in mood balance. And then also appetite and hunger and eating behavior, because serotonin mediates impulse control, and low levels can predispose us to addictive tendencies. And a lot of women start to feel some of these challenges at some point during their perimenopause, and it may be a sign of lower levels of serotonin neurotransmission. Now, this may be because estrogen is really coming down in aggregate. But even early on in perimenopause, we know that estrogen is erratic. And a lot of the worst symptoms of perimenopause are caused by the marked swings and fluctuations of estrogen, because serotonin is also going to be whipped around by those swings in estrogen. And this can definitely cause a number of symptoms. And in particular, it is a major driver of hot flashes. I want to talk about that in just a second. So please stay with me because that's the fifth key area of perimenopause that I want to dive into today. But in addition to fluctuating or progressively lower estrogen, women can struggle with a lower serotonin neurotransmission because they're just not getting enough of the key cofactor nutrients needed for optimal serotonin synthesis. This requires key cofactor nutrients like tryptophan, an essential amino acid. And in particular, your patients who are wrestling with long haul COVID or other chronic high viral load or other long standing infectious disease may struggle with having inadequate levels of tryptophan available because the immune system is commandeering a lot of that tryptophan to support macrophage function. So we need to make sure we're eating plenty of complete protein in order to get optimal levels of tryptophan. Serotonin synthesis also needs B vitamins, especially vitamin B6, which if a woman has been taking oral contraceptive pills or any type of oral estrogen, her B6 levels may be suboptimal. And we also need iron. And I've already mentioned that this is a time of life in which women may experience, in the first half of perimenopause, heavier menstrual bleeding. And she may experience some degree of iron deficiency for the first time in her life. And we need iron for the synthesis of several neurotransmitters. So we want to make sure we have plentiful serotonin neurotransmission to minimize the symptoms of perimenopause. But I want to end today with the fifth key consideration in perimenopause, which is the symptom that is often most debilitating for women, and that is hot flashes. And in particular, hot flashes at night, or what are often called night sweats, because they can dramatically interfere with sleep. And chronic poor sleep is a huge mediator of pretty much any chronic disease state. And it's also a major driver of trouble with weight loss or weight gain, because being unable to sleep deeply and extendedly on a regular basis consistently can often put us in more of a sympathetic nervous system state, right? More of that fight or flight state that naturally promotes weight gain. But hot flashes, I mentioned earlier that estrogen and serotonin are dancing together. And indeed, as we're experiencing the fluctuations of estrogen throughout perimenopause, even while estrogen levels are still moderate, optimal, or even high, they often are still fluctuating. And it is a sudden temporary drop in estrogen that can trigger a hot flash, because we also get a sudden drop in serotonin. And this triggers centers of the brain that control temperature regulation. And indeed, a woman feels like suddenly the temperature in the room has changed 5, 10, 15, 20 degrees. And she often is sweating. The surge of norepinephrine and epinephrine that comes along with that shift in serotonin can also promote anxiety and hypervigilance that makes it very hard to go back to sleep. And of course, feeling sweaty and hot is also very uncomfortable and makes it likely that a woman is often up for the night, or she may struggle with repeated awakenings because of these hot flashes. And so things that help to provide a little more constancy of estrogenic stimulation, in particular, the beta estrogen receptor, can be helpful for reducing hot flashes. And this is where, again, things like maca and ground flaxseed or isoflavones can be helpful. But in addition to serotonin, hot flashes are also heavily mediated by histamine, as I mentioned earlier, and also stress hormones. And histamine is something that, again, We can do things during our waking hours that are promoting higher levels of histamine at night that might be worsening hot flashes. In particular, consuming high histamine foods and beverages in the evening, especially fermented or cultured foods or stored foods, canned foods. Foods that have been stored for a while often have higher levels of histamine. But in particular, things like beer and wine and alcoholic cider are often loaded with histamine. And alcohol itself, as I've already mentioned, the metabolism of alcohol tends to increase histamine in the body. And so we want to think about reducing our histamine exposure and also increasing our ability to degrade histamine. And again, we need a good, rich toolbox and capability and confidence, not a protocol that we're trying to make fit for every person that shows up in our practice with these kinds of challenges. Things like quercetin or pycnogenol or diamine oxidase are some tools that can help with histamine degradation for a variety of reasons. But we want to pay attention to histamine overload and how this might be triggering or worsening hot flashes. But I also want to talk for a moment about stress hormones. Dr. Geraldine Pryor is famously quoting, I think, a truth that we've seen play out over and over again in thousands of cases. There is no protocol, no clinical intervention in the world that is going to markedly help to counter hot flashes if a woman is very stressed. And this is where your clinical approach has to take this into account, because high levels of stress hormones like cortisol or even frequent surges of norepinephrine and epinephrine are naturally going to trigger or exacerbate hot flashes because it is a stress response from the body based on a sudden shift in serotonin. And if we're already stressed about a lot of other factors in our life, it's only going to be worse. And this is where I think it's a responsibility for all of us as practitioners to talk to our clients and patients about stress and how we work to reduce stress hormones in our body. Part of that is biochemical, and you can do a deep dive and understand where poor methylation, for example, is at play, or imbalanced immune function is at play in increasing a woman's stress hormones. But often the biggest source of stress in a woman's life is in her mind. It is in her thoughts, in her attitude, her mindset, her belief system. And two women can have objectively nearly identical circumstances in life. And one of them is grateful, is optimistic, has good behavioral practices and habits of letting go of the frustrating things in life, especially the ones she can't control, and her stress levels are relatively low. Another woman can actually have the same circumstances in her life, but have behaviors, belief systems, habits that are about worrying about it, always wanting it to be better, always looking for what's wrong in her life, always wanting to try to control things and being frustrated with what she can't control, which is creating a perpetual cycle of ruminating and worry and negativity in her mind. It's really critical to teach your patients that their nervous system is not being protected from their thoughts. In fact, our nervous system is eavesdropping on our thoughts constantly in order to learn about the status of our world and whether or not our nervous system needs to focus on fighting, flighting, and hiding and being hypervigilant so we survive, or whether or not our nervous system feels like it's safe to not fight, flight, and hide, whether we feel safe and able to rest, digest, heal, be fertile, and thrive, and really enjoy life, and lower levels of inflammation, lower levels of hypervigilance, and lower levels of stress hormones. And so we need to be teaching people that their attitude, their perspective, their mindset, their beliefs are essential. And we need to start paying attention to our automatic negative thoughts and how we might be keeping our nervous system believing that we're not safe, that we need to be hypervigilant, that we can't afford the luxury of thriving and healing and feeling fantastic and sleeping deeply. This is an aspect of patient education, inspiration, and empowerment that sometimes is the largest lever for helping women to have a less symptomatic, more stable experience through perimenopause. At the end of the day, the fluctuations, the erratic nature, the shifts and twists of perimenopause are natural. They're expected. It's not something we're going to protocol our way out of. But we can partner with a unique patient and client to help them to surf the waves of perimenopause with support and confidence, by helping them to feel like they have a partner in you that can help them to respond in a flexible, dynamic way to what they're experiencing month after month, year after year during this transition. So I hope you've taken some value from today's session and are able to increase the flexibility and the breadth of your toolbox in supporting women through this powerful transition phase of life. Thanks so much for joining us. Have a great day.